I'm Andy Bressler, Healthcare Policy Analyst for Bank of America. And it's my pleasure to introduce this important and very timely panel discussion on delivering care, new tools, evolving challenges, and bold aspirations. And we have, as Chris mentioned, some of the best leaders, particularly in academic medical centers and healthcare systems across the country. I'll start it off with just a kind of a broader question overall on academic medical centers. Many are operating in the red, very challenging financial outlook overall, given the important role that American healthcare for innovations and advancing breakthrough science and educating our healthcare leaders and workforce. What would it mean for the future of our healthcare system if we saw academic medical centers become insolvent? And what do you think are some of the solutions that we can look towards?
So I'm gonna take that back a little bit and just talk a little bit about what's the status of provider health care in the United States today. Yeah. The fact of the matter is more than 50% of healthcare providers systems in this country are in the red. I had the honor of being the chair of the American Hospital Association during COVID. So I definitely picked the short straw there. But since COVID and then the financial crisis after that, we've continued to see a crisis across provider health care. One, probably each month, at least 1 to 2 rural hospitals go out of business. Now we're starting to see some of the mid-sized health systems start to struggle with their financial situation. So they've kind of worked through their reserves, and we're seeing places like Minneapolis and Portland, where some institutions that have been there for a long time are looking for cover. I think we're here in Boston. You guys haven't been in the news at all about some of the hospitals that have struggled here. So that's a trend that we're going to continue to see. And the question is what to do about that and how to deal with it. I think our colleagues at academic health centers have a unique problem as well. We're all in this together in terms of how do they make what's fundamentally important in terms of training the talent for the future and make it work. The math is difficult to work. The most important thing that we've seen over the last 2 years is a tremendous cost of labor expense combined with inflation, combined with supply chain issues that have made the business, particularly on the acute care side, incredibly difficult.
Ann?
I think you've beautifully laid out the challenges for healthcare systems writ large. And they are true for academic healthcare systems, non-academic healthcare systems, small community hospitals. It's a matter of scale. It's a matter of location, because each state has its own different challenges and benefits. Academic healthcare systems are threatened right now in a way they've never been threatened before. And I don't think it's hyperbole to say that we are at this point now where the future of academic healthcare systems is in incredible jeopardy. So you take what you've said about all of healthcare and all of these challenges, but here's that extra, what does that academic healthcare system mean? It means the other missions. It means investing in research, and I'll go back to that one in a minute. It means investing in education. It's training the next generation. In our case, it's the thousands of trainees who come in every year who are going to be leaders in medicine, in their area, in clinical expertise, et cetera. That's what it means. And thirdly, it means investing in community health. Now, almost all healthcare systems do something in community health if you're a not-for-profit, but for us, it's core to mission. So if I look at what that means in terms of the survival of academic healthcare systems, it means that across Mass General Brigham, we pretty much start out each year about $1.5 billion behind because of the critical investments we have to make, because of the difficulties in supporting excellent clinical care when you're dealing with Medicaid, Medicare, all of these things together. So it's the fundamental financials that are threatening, and all of these other challenges, workforce, providers. I mean, 60% plus of our costs are labor. All right, so where does that mean, and what is the threat there? The threat to academic medical centers we've identified, but but who cares? Like, what does that mean? Why do we, as a country, care about it? Because it is so fundamental to everything that we're talking about today. It is fundamental to the basic science, funded by the NIH, funded by a lot of things that provide so much of the basis for the innovation that then goes out into companies, into creation, into products, into new drugs, into therapies, into devices. All of that is fundamentally threatened. We need to train the next generation of leaders. Who is going to do that if these academic systems can't function? So these critical functions of academic healthcare system, I don't think are widely appreciated. They're in fact pretty much taken for granted. Oh, that unbelievable clinical care that's provided at academic medical centers that enables all that research base to be infused into that complex care, that's just going to go on. So that's really threatened. So now I'm going to just talk a little bit about what needs to be done about it. There's a lot that needs to be done about it, and because time is limited, I'll just divide it into two major parts. One of the things is what can be done in terms of governments, in terms of states, in terms of regulatory, in terms of all of these things. And again, the problems with how we support clinical care, what we're all looking at is an increased cost that keeps just going up with expenses, and revenue is pretty flat or going down. That's not sustainable. So are there ways that we can think more creatively about that from a national/state perspective in terms of doing that better? That's the first thing. The second thing is an adoption of value-based care. We have to push care out into the communities. We have to enhance primary care. We have to think about value of healthcare in a way that we just cannot possibly ignore anymore. So those are kind of two major things we have to be thinking about, and also recognize the threat. I don't think this is portrayed as a national problem. In fact, I think what all of us do is pretty much taken for granted. States are focused on a lot of important issues, transportation, housing. These are critical infrastructure needs, but not on this. Okay, last, what can we do? We can do a lot. Number one is we can look at the academic healthcare system structure, which has been the same for decades and decades and decades. So the academic healthcare system I grew up in fundamentally hasn't changed. How we think about that delivery of academic care, redefining what a department is, what an institute is, how do you reach people, how do you bring together the best clinicians and scientists and educators, clinicians in a very different model, is really calling into question some of the fundamentals of what an academic healthcare system is. We have to rethink that. Second, we have to partner more broadly. We have to get out of the mindset of we invent everything ourselves. We have to partner with government. You've heard about a little of this morning, whether it's ARPA-H, a number of other things, partner with industries, partner with other healthcare systems, and adopt new technologies in a very different way. We have invested very heavily in moving into the digital world, and I think that's just the first of many things to come. So that's a brief snippet there, so thank you.
A lot to cover there.
A lot to cover.
Yeah, Kevin, your thoughts?
Never go third on a panel behind Rod and Ann. I had a high school teacher, my favorite teacher, Rob McConnell, said, everything in life can be solved. It's a math problem. We're in a math problem right now. And appropriately, people say Medicare is funding a larger portion of care delivery. They're underfunding a larger care of.
That's right.
So at Penn this year, we're getting about 2.4% increase in Medicare. At our flagship hospital, it's 0.9%. We don't even get a full percentage point. And it's okay with me. If they want to, if that's a decision we're making as a country, you have to release me from the other obligations. 40% of our cost is spent on administration. So when you say we're going to pay you less and we're going to put in 10 more rules for you to follow, it's a math problem that's not going to solve itself. So as a country, I think we have to quickly realize that if you underfund the academic medical centers, again, I'll use Penn as an example, NIH, budget's okay, but they keep reducing the pay line of what they're going to pay for a doctor. So 60% of our margin funds research at Penn. Again, if you keep tackling that margin, I worry that it's all going to fall apart, and then we're going to scratch our heads and say why. We have a pending shortage of doctors, 100,000 by 2030. Everyone says train more doctors. We've been capped by the federal government on what they'll reimburse for residents for at least a decade. I think there might have been some minor relief this year, but essentially, if you're over the cap, it's coming out of the health system margin.
Yeah.
Everything's coming out of the health system margin. Without some relief on the administrative side, we're just going to continue to struggle to the point where I'm afraid it's going to strangle and really slow down the progress that we've been making.
That's great. I want to get back to something that Ann mentioned about collaborations and maybe talk a little about some of the things that now that are working well. We've heard about sort of a lot of the problems, but where do you kind of see the ship kind of turning around and things that you're doing, whether it's here in Boston or out west, or Seattle or in Philadelphia? What are the couple of things that you're working on collaboration-wise that you go, gee, this is really making a difference?
So I just start out, over the last 8 years, we've hired non-healthcare people. So if you look, my CFO came from T-Mobile. We've hired away from Amazon and Microsoft because healthcare people know the healthcare stuff. We're there. But we really had to disrupt ourselves and bring people in. The Amazon people that came into Providence, they were having spasms of watching the way we were doing our business and really changed our culture. So we completely digitized our operation. We have the largest single instance of Epic in the world. We have one ERP across 7 states. It's no small task. We have 121,000 people that work for us. And we have 1,000 clinics and 51 hospitals. But from a business standpoint, we've said we got to get our hands around this, but we need to get the help from outside of healthcare. The other thing that we've been pursuing is that all the administrative side of what Ann and Kevin and we do, why do we do that all ourselves? Revenue cycle, IT services. So we're really looking at collaboration across the healthcare spectrum and saying, let's just do this together. We can own it. I'd rather own part of an entity that's successful than try to do it myself. So we're looking at how do we revolutionize that. Then also, I think the things that we've underestimated is the value of our data. And we're slowly waking up to that we're sitting on top of a gold mine. And we've started to collaborate now with 32 health systems, putting all of our data together in an entity called Truveta. And we said, I don't want to give it over to Google or to Facebook or to someone else. And we want it because we think folks like ourselves know how to use it for good, not evil, in terms of really moving things ahead. So we put a lot of time and attention into those areas. But those are the things that we're going to have to do while we're complaining about what's happening to us. I think, as Ann and Kevin have said, we've got to figure out some things that we have to do to change what we're doing. And the 3 of us are big enough that we can kind of move the dial a little bit and really kind of change where we're going.
Yeah, I think partnerships, again, are key. I'd mentioned that. And again, they come in all different ways. The industry partnerships are certainly valuable, and I'll talk about that in a minute. I think one of the points you made is really critical, which is you've got to get outside of healthcare and you've got to look more broadly. I mean, as someone who's been a researcher for many years in my past life, there is no such thing as a research project where you go to the knowns and then stick to the knowns, and then you're not going to get anywhere. So you really have to think very broadly about what are the different types of skills you need, what are the different people, and think well beyond your own lab. And it's the same principle here. How do you get beyond your own healthcare system and think of things in very different ways? So I think in terms of industry partnerships, I'd probably divide it into 2 just quick examples. One is clearly moving toward a more digital organization. So, when I took this job, although I've been in the system pretty much my whole life, 6 years ago, there was a lot of struggle going on in terms of, well, what does it mean to move to the cloud, and what does it mean? I mean, there was a lot of discussion among people, really great people who had been there a long time, but had spent their whole lives in healthcare in an organization. And one of the first things, well, not one of the first things, but along the way, when we started thinking about what it really meant to move into a digital organization, what that meant for patients and what that meant for providers, what that meant for the system, the first was to go and bring someone in for the first time to run all of this, the data, all of cyber, all of e-care, which is our Epic. And that was hiring Jane Moran, who came to us from Unilever. And people said, well, but that's not a healthcare company. And we all said, no, it wasn't, and it's not, but that's really not the point. And I'll give a special thanks to Ron Walls, who was our Chief Operating Officer, who really, I think, helped bring her, who got her here. And she's just been fantastic. Why? Because she has an incredible amount of experience in these broad structures in multiple countries, so we were able to do that. Partnerships, we partner with so many, there are probably a list of 20 companies we have partnerships with in that space alone, and they range from big companies like Microsoft to smaller companies. You heard about a bridge today. So it really encompasses a lot of the different work that we do. So that's one thing. I think the second thing is Jonathan Kraft mentioned home hospital today, and I'm really thrilled that we are the largest home hospital now in the country, even though it's still small and we're growing. And the question is, how do you get that technology in, and how do you get that technology into the home? Because we don't do that. That's not what we do. And that led to a wonderful partnership with Best Buy Health. That's what they do. Think about what Best Buy has done. They bring technology into the home. That's what they're known for. So these kind of partnerships are really fantastic, and they can be very broad or they can be very narrow. And then the last thing I'll say is just partnering with other healthcare systems. And some are very academic healthcare systems, some are community healthcare systems. We do a lot of partnership. Depends on what we're doing. We just announced a partnership with Tampa General, which is very interesting because it is a way of providing care in the state of Florida together with a leading healthcare system in the area. I think it's a very different model from hospital or system expansion, which traditionally has been to just buy more hospitals. And I don't, I think it probably very much depends on the system and what you're doing, but for us, that hasn't been a tremendously meaningful way forward.
Kevin?
I would just add two things. Ann touched on it first. We needed to go through a sea change of what it meant to be a faculty member. And when I first started in the business, you did research, you taught, you did clinical care. You were a triple threat. It's not possible to do those three things anymore, but so many of the young people have added, I do clinical care, I teach, and I'm a CEO of a startup company. They want to be entrepreneurs. So the triple threat has evolved. It took us a while as an industry to embrace that change. Now that we have our industry partnerships, I think the most successful ones were when we set out and say, what are we going to accomplish together? And if the answer is return on stockholders' equity, that's not going to work. If it's going to be, we want you to provide free services to Penn, that's not going to work. So we try to ground it. Our best example would be our work with Novartis back in 2010. And it resulted in the first FDA-approved gene therapy. But it started out with, what is our goal? And our lead researcher said, I want to get this drug into patients quickly and safely. And that became our mantra at every meeting, quickly and safely, not, again, return on stockholders. And once you were grounded in a common ethos, I think partnerships are just a fantastic way for us to accelerate the learnings at the health system.
That's great. Kevin, I want to go back to something you talked about was obviously Medicare reimbursement has been under pressure, obviously. Managed care payers, always kind of pressuring you guys. Can you talk a little bit about where you see both on the managed care side, commercial payers versus Medicare, and how you can kind of get that message that you mentioned, Ann, that hey, you're providing something that's even maybe bigger and more important for the longer term health of our whole healthcare system. But payers are really focused very narrowly on the year-to-year reimbursements or on how much can they get away with not paying you. So how do you kind of bridge that gap?
We're going to continue. As a country, we've talked a lot about value-based care. We haven't achieved it yet. Until we realize less is more and really embrace that, it's just, we're stuck in this perpetual cycle. The best example I can give you is CMMI put out a mandate. They were going to do a pilot on radiation therapy, and they would pay us per episode versus per click. Our doctors work so hard to reduce a number of radiation doses per patient. And then CMI announced we're not going to do it. We went to our local managed care company and said, okay, why don't you pay us on an episode of care? And they said, why would we? You've reduced the per treatment so much, we'll just keep paying you on per treatment. So we have to stop talking about value-based care and actually do it, or we're going to be caught in this perpetual cycle. I have a diabetologist, I thought about it this morning. Diabetologist said I could treat 200 patients a day virtually through their primary care doctor using a platform similar to Stability Health, or I could treat 40 the way Medicare wants me to do it, which is I have to see them, I have to do all the exam, I have to document it. Wouldn't 200 patients be better than 40? And the answer is of course, except the regulations are written to maximize the incent the 40 versus the 200. So I'm looking for a sea change.
Yeah.
I'm hopeful. I'm getting towards the end, which makes me cranky, but I am trying to be intentional with everyone that we talk to. Again, the debt service alone in Washington that we used to talk about, we no longer talk about, is strangling what Medicare can pay. So again, just release some of the old-fashioned ways of doing things, and I think we can survive. But if it's keep doing it the way you've always done it, we're just going to pay you less. Right. We're headed to a brick wall.
Yeah, I mean, I 100% agree with it, and I'd also say just thinking about things like home hospital, which is less expensive, has better outcomes, clearly demonstrated for probably 25 years. We're always sort of worried about what that means, virtual care, behavioral health, all those things. But I'll just take a little bit of a different angle, going back to the point of what can we be doing in terms of that, aside from telling the story and trying to be as efficient as we can. And I'm just going to pick up on the value-based care and what's the value of the care provided and what it really looks like to democratize care from an equity perspective, from a best care perspective, and also get it out into the community. And I know you've done a lot of that work at Penn. You just heard earlier, and I'll just pick one example of a new model of cancer and the fact that Dana-Farber is going to be leaving Mass General Brigham and joining BI. You heard about that earlier today. And I think that's just a phenomenal opportunity for us, because as a very large, comprehensive healthcare system. You know, we have 85,000 employees now, almost all, not all, focused in Massachusetts. We have a singular focus on high-quality care, the best specialist care, all of that. And for us to be able to now create Mass General Brigham Cancer, and here's the point, get all of that care not only at our flagship academic medical centers, Mass General and the Brigham working together, but also into our specialty hospitals and our community hospitals and our outpatient sites and our community sites, and taking that kind of cancer care within the context of an academic healthcare system and getting that care out into the community, which is what we do with all kinds of care all the time, that will lower cost. And really being enabled by the state, by the government to do that, get that care out closer to home, democratize that care in community hospitals and ambulatory centers. That will lower the cost of care. That will not solve your collective math problem, but it does actually help in terms of the kind of work we can do. And we can say that to the government. This is what we've been able to do. This is what we can do in primary care. Here's what we've done to lower the cost of care. Now it's your turn.
Yeah, I would add a couple of things to both points. One, you have to look, when you look at the total healthcare budget, what percentage of that budget actually goes to taking care of patients, training doctors, and doing what we do? Yeah. It's in the 40% range. And what you have to look at, and Amazon's really good at looking at where's the value equation and who adds value. And I can ruffle maybe a few feathers in this room, but when I look at my colleagues in managed care, I ask what value do they add for what they make? I know what we do. I can see that. But I think the public has to ask that question, the government has to ask that question. when we talk about value-based care, the government needs to shift and say, that's the only way care is going to be delivered. This is what happens. We made a proposal when Senator Sanders was talking about Medicare for all.
Yes.
We said, why don't we just look at primary care for all Americans, 330 million Americans. Let's guarantee them all primary care. It's only 9% PMPM of the total dollar cost of health care, but it's the most important 9 cents you're going to spend. And what that would do immediately, if all of that was value-based, whether it was commercial or government, it would make primary care nirvana, because they could practice the way they want to, use virtual care, use nurses, use everything else. And on top of that, guess what? The health of the United States would go up exponentially.
Yeah.
So those are solutions that are staring us right in the face. It really, the money's already there, right, Kevin? I mean, it just says, let's do it a different way. And it's the way that doctors want to practice. It's the way patients want to be seen.
Yeah.
And it's not, we've modeled that out for folks in Washington. We just need to have that will to do it. Those are things that are going to fundamentally change the way we're delivering care, which is a model that we've gone after. And if you talk to any primary care doctor, they're so disheartened. They're
Yes.
on a hamster mill, and they're not practicing medicine they want to. You make this shift, it changes everything dramatically.
And that's great. Just a reminder, if you have any questions, you can put in your questions into the app, and I'll get to see them up here, and I'll make sure that we relay them. But it wouldn't be a healthcare panel these days if I didn't mention artificial intelligence and get your reaction to how you're kind of moving forward on developing and utilizing artificial intelligence, both for patient care, but also for research and innovation. What are you guys doing? And I'll start with you, Ann, on this.
Oh, sure.
Right here, I know there's a lot going on that you're looking at in that area.
Yeah,
so.
there's a tremendous amount going on. I would say, first of all, to just the data issue that came up before and the value of data. I mean, that's something that we've been working on for, I'd say, a number of years. It's the data, but it's also the highly curated and validated data, and it's the longitudinal data. So what we learned over many years is that just looking at data in an electronic healthcare record, whether it's ours or ours plus, add in the pluses, only means so far. I mean, you know, you use the coding data for diagnosis. Depending on what you're doing, it's wrong up to 30, 50% of the time. So you have to have highly curated data so you actually know what it really means, so that it can have real predictive value in terms of patients. What are those algorithms? But the power of healthcare system data is its longitudinal nature. Because if you're looking at, you know, what the right endpoints are, what's the right way to do large scale trials using data, how do you predict efficacy of drugs, you know, you really do have to have longitudinal, highly curated data. So in the data thing, or area, we've been doing this for a long time. Bringing in artificial intelligence has just really enabled us to, you can screen, with the compute power that's out there now, and that's not even saying what it's going to look like in a year or 5 years, you can do an enormous amount of this work that used to take thousands of hours to do in a very tiny amount of time. So it enables you to index data, categorize data, have predictive algorithms with data. So we're doing that, and that's a very powerful thing. Sometimes with companies, sometimes ourselves. So I think that is going to completely change around how researchers work. And we're already seeing it because, again, we've democratized the data and are continuing to do this. So you don't need to go to the experts to ask your question. With AI, an individual researcher can ask a vetted question and get answers that, again, normally could have taken 4 study coordinators, you know, a year to get. So that's all fantastic, and I think we're going to be seeing more and more of that. And then you've got the issues of how do you actually think about data from an integrity point of view and using AI algorithms in an equitable fashion. So that gets into all of the issues of, are you using data that's representative enough to draw a conclusion? Are there inherent biases in the data? You know, we do a lot of work with ourselves in partnership with MIT. We have a long-standing partnership with GE and other companies. And it's always the integrity of the data, meaning whatever it is you're putting in, if you're not watching what you're putting in, those rules can lead you to conclusions that may not be valid. So a lot of work is being done on that. I think on the clinical side, it's been incredible. And and I think this was mentioned earlier today by Jonathan Kraft. Lightening the physician burden by having the ability to use either of the tools that we're using now, either Bridge or Microsoft, to actually have a physician just talk to a patient, not look at a screen. And then what you get back, it's not a transcript at all. It's an AI-generated note that is absolutely phenomenal. I mean, you have to see it. There's over a 95% adoption by our physicians. That's incredible. I mean, when have we ever seen anything with a 95% adoption? I would like to know, because that to me is extraordinary. And people are signing up, more and more doctors, nurse practitioners, et cetera, want to do that. So I'll just summarize it in saying a lot is being done there. I'm also looking at those opportunities in other areas. You mentioned things that you might outsource, like supply chain, all coding. There's lots of work being done in that. But I do think that there are large chunks of the healthcare business that we're still doing that honestly could be done in a very different way. So we are looking for those collaborations, because those are not healthcare specific. They are hardcore to healthcare and our expenses. And last thing I would just say is the potential of this in human resources, in HR, to actually screen candidates, get the best candidates, do things in a way that is bias-free and brings the best candidates forward. So.
Kevin, thoughts on AI?
I would add two things. One, our approach is more on the repetitive human function than it is on the clinical side right now. And people fly into our hospital all the time from around the Mid-Atlantic, and I hate when I hear, well, we lost a day length of stay because we couldn't get insurance approval. And that's just somebody calling someone, going through, it's just an algorithm. And that algorithm can be built into AI and speed up and much faster in going through that. So I think those repetitive human functions are the first place that we should tackle it with AI. The other part that I'm most interested in is AI for public health. So in America, we love to say everyone should get equal access, everyone should be treated the same. American Cancer Society says if you hit age 40, you should get a screening colonoscopy. If you call Penn, the next available screening colonoscopy is 6 to 7 months away. And we'll probably tell you, call in 6 or 7 months because we're not taking reservations. Everybody doesn't need that same level. If you have a genetic makeup, if you, where you lived, by a highway, all those environmental factors that come into healthcare, I think AI will help us become more precise in delivering our care so that we can actually take care of the people that need it and get off of this one-size-fits-all, which is pretty much how American medicine's currently delivered.
I would say the most important thing in AI, the three of us are enthusiastic. You could put three more of our colleagues up here and they'd pour water on it. What every health system has to do is set up a structure for AI.
Yep.
So I can assure myself that my two colleagues, before they dove in, said, okay, we need a structure built around that that includes the ethics of how we use it, how do we make decisions on where we're going to apply it, what are the effects, all of that. So to my colleagues that say they don't, it's like, I don't want to use an iPhone, okay. But so at least put the structure in place because it's there already. So when we looked at ChatGPT, we created an internal ChatGPT for all of our people inside so we could secure the information. Then what we did with every department, we said, give the 2 AI applications that will change your business for the better. And it included, to Ann's point, the business people and the clinical people.
Yeah, it's different.
So in the medical group, what we went after, which you guys probably have done as well, the in-basket, which is the bane of every doctor. So now we use AI-enabled things so the doctor is only getting the things the doctor actually needs the doctor's opinion on. We used AI to work on our scheduling in the ORs to figure out how to, this is worse than landing planes at O'Hare, is to get surgical schedules the right way. But it's, like my colleagues are saying, 90% approval rating. They're saying, finally, you're doing things that are actually making my life better as I go forward. the vision of what I see between AI and the data, I think it's the equivalent of going from Galileo's telescope to the Hubble to the web. Because what happens when you look at data patterns over literally tens of millions of patients, we start to see things we didn't see before.
Yep.
And that, to me, is the most, it's the best of times and the worst of times in medicine. The best of times is we are going to be able to see in our lifetime things that we were never able to see before that will really change the way we care for people. And that's what's exciting to the three of us.
That's great.
Just before you go on, I really want to emphasize the point about governance. That governance and structure for dealing with all of these issues is just monumentally important, whether it's the introduction of AI, whether it's how one uses data, what are the guardrails around it, what is a partnership, how do you define equity in data? Without that governance structure, it is highly problematic because it just becomes everyone doing what they think is right, and that again is problematic. The other thing that you mentioned that I also want to emphasize and highlight is I think when all of this started, the question is like, who's the AI expert in the institution? Like, who's your AI expert who can do this and this in this department? And it's completely not that now. I mean, obviously you have people who have a great deal of expertise, technology, relationships, et cetera. But again, I'll use the word, it's been democratized. So every single person and so many people are using ChatGPT in their everyday functions. Whether their supervisors or their department chairs realize it or not. So a lot of it is just understanding that it is already being deployed. So it's interesting that you have your own internal version, but if people think, I wonder how to introduce ChatGPT to my institution, it's already there. It's everywhere because people are using it all the time, even if you as an individual are not.
Absolutely.
Yeah.
Turning to another big topic that you guys have had to deal with the last 5 or 6 years, well, you really always have to deal with it, but the last 5 or 6 years on labor costs, staffing shortages. Coming through the pandemic was a huge hurdle with all of those issues.
Yeah.
What did you learn through all of that? And now what do you see kind of going forward that you're kind of doing differently now that you have to deal with sort of a different environment? And maybe play it into what you talked about before, Ann, which is the shifting of care, out of the hospital to the outpatient setting, to different types of settings, and getting out into the community versus everything being done right in the 4 walls of your big hospitals.
What I would say, just quickly, we'll never have enough doctors. I said this 10 years ago. It's still the same. We're never going to have enough nurses. So
Yes.
what we need is to let doctors and nurses work at the top of license with being technology enabled and really being able to use other resources to get through that. That's the only way that we're going to see ourselves through what are some of our most essential people. Technology today, I'm on the board of GE Healthcare. We're starting to design ultrasound that can be done by anyone.
Yeah.
Because it's using AI tools in order to do it. So that's the only way out of what we are. If you look at the three of us, we all spend greater than 55% and more of our budgets are labor. And how do you deal with that? How do you make that work? If we don't solve that issue, workforce, we're not going to get there. The last thing I'll say is we've been inflexible in how we schedule our people.
Yes.
And we got to get over that. One nurse came to me and said, look, I can only give you 2 shifts. You guys have a rule that it has to be 3. We can't do that anymore. So it's all of those things that are going to help us make us smarter as we go forward.
So maybe 3 quick things. Number 1 is the world may have moved on past the pandemic, but our workforce has not. And so whatever challenges were there before, they're real, and they're getting worse. So this concept of, I had a hard time during the pandemic, I couldn't leave my vacation home, does not apply to our workforce. So I think that's the first thing. And it's really important for everyone to recognize, and it is forgotten every day. Second thing is having people work at the top of their license is critical, and I want to talk about that just briefly because it is redefining the work. Who does the work? So if your physicians are working at the top of their license, they're not spending 40, 30, whatever % of their time doing administrative work. What is a nurse? What's that role? What does a therapist do? How do you define this? So all of these things are coming into play, and I think that's important. And then the third thing is, the word pipeline is used in different ways, and it's often misused, but what's the next generation of people coming? We knew there was going to be a massive retirement of nurses even before the pandemic, just tracking the trends. So we have worked very hard across MGB, whether it's this Bloomberg Foundation grant partnering with the city, with the superintendent of public schools, the mayor, all of that work that was done. We've developed a partnership with UMass, and that has enabled us to bring in a more diverse set of candidates into the nursing pool and guaranteeing them spots. We've done things with local community, colleges. We've just done a lot of work in the behavioral health area to bring in more of a workforce. So a lot of it is just partnering with the communities around us to try and bring in people who will be helpful to our future workforce. And that's always been somewhat of a concept. Now it's just more of a reality.
Kevin? I think we're almost up, but
Yeah.
if you have any last words for us on labor costs?
I'm going to go with we have to do better. We have to do better as a healthcare system. The example I'm going to give, this relates to the workforce. We'll be first in humans in flash radiation. So rather than coming in and getting 24 to 30 visits for a brain tumor, you'll come in once. And that's all you have. That's going to be better for the patient, and it's going to mean I'm going to need less workers, therefore I can pay the workers we have more.